Welcome to the lecture for crisis intervention. We'll be talking this time about post-traumatic stress disorder, or PTSD. So we start off talking about why a discussion of PTSD is relevant to crisis intervention, and several reasons. I'll just highlight three of them here. One, it's possible that crisis is caused by someone's reaction to trauma, right? Where somebody experiences a traumatic event and they develop post-traumatic stress disorder. And then their reaction to the dealing with that and kind of the fallout of suffering from the symptoms of PTSD might put them at greater risk for experiencing other crises, right? Relationship crises, problems at work that lead to a crisis, struggles with substance use. Right? Somebody might come in and it may not be the first time that they're diagnosed with PTSD coming to see you, but because they have PTSD, if they've been diagnosed with PTSD, it puts them at greater risk than somebody in the general population for experiencing other crises. And if you think about their kind of resources have been depleted to some degree. Otherwise, they wouldn't be suffering from PTSD probably. Another thing is that more of what you would typically think is that a crisis can be the cause of the trauma reaction, where somebody might be coming in and the crisis is associated with some sort of traumatic event, and they're in the early stages possibly of developing post-traumatic stress disorder, right? So in crisis intervention, you may be seeing somebody, and what you do may determine whether or not they develop all the symptoms of post-traumatic stress disorder or not. At least it might determine the course, the outcome of their disorder, how soon they're going to recover. Right? And it's also important because of the potential for vicarious traumatization. Right? This is just the simple fact that doing crisis intervention work, talking to people about crisis situations, is an intensely emotional experience. And if they're talking about traumatic events, it puts the interventionist at risk for being traumatized herself or himself, and possibly even developing post-traumatic stress disorder based on hearing someone else's accounts of a traumatic event. Okay, important to talk about. So it's important to be familiar with the diagnosis, phenomenology, etiology, and treatment of PTSD if you're going to be doing crisis intervention work. Okay. Looking at PTSD, the DSM criteria, the person's exposed to a traumatic event in which two things were present. Basically, defining a trauma. One, they experienced, witnessed, or were confronted with an event or events involving actual or threatened death or serious injury, or a threat to the physical integrity of self or others. Okay. And so it's important here that you don't have to experience it directly. It can be witnessed or it can be confronted with events. So if somebody tells you about traumatic events, that could possibly qualify as a traumatic experience as well. Death and injury, people are usually pretty clear on that. Sometimes people wonder, but what does threat to the physical integrity of self or others mean? I think the main reason that's in there is to account for those attacks on your psychological self that can occur in the absence of physical attacks. So things like rape often involves an attack on the physical self and on the psychological self. Sometimes there's less clear physical attack, especially if we have rape within the context of marriage. So forced sexual intercourse where there's not a threat, not physical violence isn't used, but psychological violence, manipulation is used to force someone into having sex against their will. It's still rape, and it threatens your physical and the integrity of yourself. And so who you are and how you see yourself, even if it's not causing direct physical harm. And then criterion A2, which is what we'll talk about. The response to trauma at the time involved fear, helplessness, or horror. And in kids, this could have been manifested in terms of disorganized or agitated behavior. So they just they weren't saying, "Oh, I'm so scared, I'm helpless," but they couldn't get it together. They weren't doing anything in an organized fashion. They weren't trying to, they couldn't try to escape whatever was happening, couldn't organize the behavior, or was just agitated behavior. This criteria is being debated right now a little bit in the research. People are looking at whether or not these particular emotional responses, fear, helplessness, and horror, are really required to develop the symptoms of PTSD and to merit a diagnosis. The idea that people may experience other emotional responses, maybe anger during the trauma, or profound sadness, and might those emotional experiences still lead to the development of this chronic post-traumatic symptoms? And it's also possible, we're also looking at, there are individuals who are desensitized and trained to suppress fear, and because of that, they may not have an initial strong emotional reaction. Whereas think about our military that are trained not, you go through all these scenarios and you imagine the bad things that can happen, and they do that to try to keep people from becoming disabled in the course of battle. Right? You have to say battle ready, and so if they don't experience the fear, the helplessness, and the horror when really crappy, horrible stuff is happening, because they're trained not to. Right? Might they still develop PTSD? And one thing that may happen with those individuals, they may not experience it at that point in time. So when the traumatic event, or generally be thought of as the traumatic event, is happening, not a lot of fear and helplessness and horror, because adrenaline's running and really psyched. Then later, hours later, a day later, they think about it and they remember what happened and they go, "Oh my God!" And then the horror, the helplessness sets in at that point in time. And so really the traumatizing event, the event that leads to the development of the symptoms, is recalling a horrific experience, not the horrific experience itself. Maybe. More research is needed to verify this. But in general, at some point, there's fear, helplessness, and horror. So it's not just something bad happens and you have these symptoms, because not everybody has symptoms. And it's generally thought that you only develop symptoms if you have some sort of strong emotional reaction at some point in time. Okay. So the traumatic event is re-experienced in one or more ways. And for most people, it's a mixture of these things, and it could be recurrent and intrusive, distressing recollections of the event. So these are memories, but you still know where you are and who you are. So this isn't dissociative flashback stuff. This is just memories. And in kids, it can show up in repetitive play related to trauma. So if they were in a car accident and they keep having cars crash into each other, that counts as a symptom. Recurrent distressing dreams of the event, which for kids, they may not remember the content of the dream because of their cognitive ability. So if they have, after a traumatic event, if they have scary dreams, they wake up and they know that they had a scary dream, but they don't know what it was about, that counts. And then acting or feeling as if the traumatic event were recurring. And this is your dissociative flashback, which is qualitatively distinct from remembering. So there's remembering, and then there's feeling as if it were happening again. So that's where you're going back and you're no longer present in the current situation. You're back in that time, and you're feeling like you're there. You're acting. You're fighting people, defending yourself, whatever. But you're not really in that place in reality. And then we have two other criteria which are very similar for the re-experiencing. Intense psychological distress at exposure to cues that symbolize an aspect of the trauma. So if you encounter something that reminds you of the traumatic event, of the bad thing, having intense psychological distress, getting upset, getting anxious, getting scared, getting angry. So responding to these cues psychologically counts as re-experiencing. But then so there's also physiological reactivity on exposure to internal or external cues. Right? So, and usually it's some of the heart rate increasing. And we put those things in, the psychological stress and the physiological reactivity, because some people may deny the other symptoms of re-experiencing. Nope, never happened. And they may be so good at avoiding their memories that they don't re-experience because they're very strong-willed and rare, but they may be able to kind of push all that stuff back and really have some strong repressive skills. Talk about defense mechanism. But even if they are able to push that back, it's still the fact that the trauma is still there and still bothering them will leak through in terms of if they ever encounter cues, and again we're talking about internal and external cues. So you see if it was a rape and you see somebody who looks like the rapist, heart rate goes up and you get really scared. You may not even know why. That would count as re-experiencing. And then internal cues, which is one of the things that's can be really tragic, especially for sexual assault cases. Somebody that has is sexually assaulted thinks that they're fine, moving on, and then they are engaging in normal sexual relations with a partner who they trust and love, and then the internal experiences that they experience during intercourse might serve as cues, because they may have felt some of those same internal feelings, physiological reactions during the assault, and that can serve as a cue to bring back the experience of the assault, and then they have the physiological activity, the psychological stress, and they're re-experiencing it at some level. Okay, so re-experienced in one or more ways. Persistent avoidance of stimuli associated with the trauma, and numbing of general responsiveness, as indicated by 3 or more symptoms. So you have efforts to avoid thoughts, feelings, or conversations associated with the trauma. Efforts to avoid activities, places, or people that arouse recollections of the trauma. Inability to recall an important aspect of the trauma, so some dissociative amnesia, we might refer to that as, where they can remember other stuff before and after that event, but pieces of that event, no memory for. Markedly diminished interest or participation in significant activities. Again, the idea there is you are pulling back from life. So significant is going to work, going to school, hanging out with friends. You don't do it. You're not interested in doing it. And the idea that you're pulling back from that because you want to avoid this memory. And if you're with people, you might something they say or do might remind you of the thing you're trying to avoid. So the easiest way to protect yourself is to pull back. Right? And then feelings of detachment or estrangement from others, right? Which is very similar, so just pulling back on an emotional level. Restricted range of affect, right? So if feelings have now become scary for me, and I can start thinking of this thing, I start remembering stuff, and I get really anxious, and I feel real emotional and scary. Okay, fine. I'm not going to feel anything. I'm not going to let myself get too happy, too sad. I'm going to stay right here, and I'm going to avoid things that make me too happy or too sad, and they end up having a restricted range of affect. And they might also have a sense of foreshortened future. This idea that I can't picture myself being around forever. I can't picture myself being somewhere in 10 years. Not that they're actively suicidal. They just have this sense that they're not going to be around. And it may be that having a sense that you're not going to be around is reassuring. Because if I'm not around, then this can't keep hurting me. Right? I can finally avoid the memory if I'm not going to be here. And again, it's not suicidality, but it's just a general sense that I'm not going to be around. Foreshortened future. So re-experiencing avoids the numbing, and then the third big part would be persistent symptoms of increased arousal, as indicated by 2 or more symptoms. You have kind of this affective numbing, but in combination with the numbing, you have increased arousal. So you're trying to avoid this memory, but it seems that part of, again, almost like that thought suppression OCD, the more we try to push down against part of what we naturally do, our body pushes back, and this arousal is part of that push back. So increased arousal, difficulty falling or staying asleep, irritability or outbursts of anger, difficulty concentrating, hypervigilance, which is always being on the lookout for threats, and then an exaggerated startle response. Okay. Now, some of these symptoms, and we'll talk about comorbidity, will overlap with other disorders. especially if you think about depression with difficulty falling asleep, irritability, concentrating, difficulty concentrating. Those are all things that are features of depression. So what if you had these symptoms before you experienced a traumatic event? Well, to count toward a diagnosis of PTSD, those symptoms have to have gotten worse after the trauma. Otherwise, they don't count toward the PTSD diagnosis. Okay. So that's the heart of the diagnosis. And then a couple other things. The duration of the disturbance is greater than a month. And I have in parentheses here ASD to remind me to talk about acute stress disorder, which is a diagnosis that you could be diagnosed with if you had generally these symptoms, of re-experiencing avoidance, numbing, and arousal for less than a month. And they put in this 1 month proviso because it's expected that if you experience a traumatic event, you're probably going to experience a lot of the symptoms. And most people experience some of these symptoms shortly after a really traumatic event. It's common. It's a normal, statistically average reaction. The idea being we want to separate from normal reactions from pathological reactions, saying, well, it's only pathological if you keep having these reactions after a month. How did they figure out a month? They raised their hands and voted based on their clinical experience about how long they thought should be required. Okay. So you have to have it for longer than a month to distinguish it from non-pathological. Well, then if you have to have it for longer than a month, why do they have this other disorder, acute stress disorder? Well, because some people with that have these reactions will go on to develop PTSD. And if you say, okay, well, it looks like you might have a problem, but we got to wait another 3 weeks before we know if you have a disorder before we can treat you. Because of that, you have the diagnosis of acute stress disorder, which you can be diagnosed with if it's less than a month, but after a month, you no longer carry that label. It either becomes PTSD or you're no longer have a diagnosis. But you have this intermediate diagnosis of acute stress disorder so that people can get help. And not all people that are diagnosed with acute stress disorder go on to meet criteria for PTSD. A significant proportion do, but not all of them. Nonetheless, and part of the reason not all of them go on is it could be that if people are diagnosed with acute stress disorder and they receive appropriate intervention early on, they won't develop PTSD. And that's another good reason to have this intermediate diagnosis, is if we can target treatment earlier, maybe we can prevent these more chronic problems. Okay. And last we have causes clinically significant distress or impairment, which pretty typical to have distress and impairment if you're having all those other symptoms. Okay. So quick summary of PTSD, because it's a lot of symptoms talked about. But basically, you need to keep in mind that it's a traumatic event and then 3 clusters of symptoms. The 3 clusters are re-experiencing the trauma, avoidance and numbing, and increased arousal. Okay, and that's those are the essential features of PTSD. Okay, the experience of PTSD, we look at the onset and prevalence. Lifetime prevalence around 6.8%. And although men are more frequently exposed to traumatic events than are women, women are more often diagnosed with PTSD than are men, 2 times as much. Multiple competing theories about why that's true. In terms of onset, the symptoms are typically present shortly after traumatic exposure. The DSM allows for specification of a delayed onset, and delayed onset PTSD is when symptoms don't show up until 6 months or more after the traumatic event. But in the past several decades, that's found to be really rare. And probably because people know more about it. So people may have had PTSD before, but they didn't report it early. So they reported delayed onset. They really had symptoms early, but they weren't talking about it. And there's some other political stuff we won't get into. But usually people have symptoms soon after, hours, days after the traumatic event. They'll start having some symptoms. Because again, even if you don't have PTSD, after a traumatic event, you usually have some of those symptoms right away. Right? In terms of comorbidity, high rates of comorbidity, most often other anxiety disorders and mood disorders. When it's comorbid with other anxiety disorders, usually the other anxiety disorders precede PTSD. So having an anxiety disorder is maybe a risk factor for developing PTSD if you experience a traumatic event. But then things like alcohol abuse and depression, when comorbid with PTSD, typically follow it. Okay, so they may be more a result of the PTSD symptomatology. Another thing that's important to consider is the impact of PTSD on relationships. It can be difficult and even scary for a partner of someone with PTSD, especially if they're reenacting traumatic events and they have angry outbursts. That puts a lot of strain on relationships, especially talk about marital relationships. And there is an increased risk of partner violence in couples where one of the partners has post-traumatic stress disorder. And that's one of the reasons when you think about treatment, couple and family therapy, in addition to individual therapy, is associated with better outcomes, because the disorder affects more than that individual. And that's true of all disorders, but especially PTSD. It seems to really have a strong impact on people's relationships. Because remember, part of that, the avoidance cluster is about pulling away from people. Right? So if we want to treat them, we need to teach them and teach them how to be close to people without getting angry or getting hurt or hurting them. Again, in terms of the experience, it's been proposed that there are different neural pathways involved in the processing and storing of verbal memories and sensory memories, so these separate memory systems. And typically, interconnections between these pathways allow for a fairly seamless retrieval of memories with their semantic, sensory, and affective components all together. Right? You can remember your last birthday party. You know, you can kind of describe semantically what happened, kind of remember how you felt. You can probably picture the cake, whatever, because this stuff's integrated. But the one thought is that perhaps during traumatic experiences, these pathways are so overloaded due to too much stimulation. You have too much neural activity in the amygdala sending off these projections and whatnot, and the two symptoms become disorganized. And we know that people with PTSD, if asked to describe their traumatic memories, they do so with a greater degree of disorganization than other people that describe traumatic events that don't have PTSD. So there's something about how they're encoding or retrieving, probably both, their memories. And the idea is that there's some separation there of parts of the memory. Okay. Related to that is the idea of overgeneral memory. Consistent with, like I said, people with PTSD seem to develop an overly general memory, where after the trauma, memories are less detailed and less specific. They're overly general. And this seems to indicate an adaptive response whereby the person is trying not to remember certain things. And because of this kind of strategy of trying not to remember these traumatic events, they end up being unable to remember other unrelated things and having this overly general memory. So again, getting them to focus on details may be part of treatment. In terms of identifying neuroanatomical abnormalities, brain imaging studies and neuropsychological testing, like the Stroop task, suggest that individuals with PTSD may experience a hypoactive medial prefrontal cortex. So that part of their brain might be underactive, not doing enough, but then a hyper-responsive amygdala. So now whenever emotional messages come in, and the amygdala is involved in the processing of emotional information and memories, the amygdala fires off too much in response to stimuli. So might be one of those, might be both. Again, not sure, but there do seem to be average mean differences between groups, people with PTSD, people without. Okay. In terms of etiology of PTSD, obviously you have to experience a trauma. You can't have PTSD without trauma, but not everyone who experiences a traumatic event develops PTSD, so there must be more to it than that. But before we get to that, one thing is that people probably differ in the likelihood of experiencing a trauma in the first place. And there's certain individual characteristics. There are certainly social characteristics. You know, if you live in a more impoverished neighborhood, you may be more likely to experience trauma. But other kind of interesting individual factors include having certain personality styles, being an extrovert, generally thought of as being a good thing, puts people at risk for experiencing traumatic events. And it may be the part of extroversion, because extroversion is a big concept. It may be that part of extroversion that's led to high sensation seeking and not being inhibited by rules or prohibitions. People that are kind of risk takers, willing to try new things. Some new things are more dangerous than others and may lead to traumatic events. So some people may be more likely to experience trauma in the first place. Like I said before, men are more likely to experience trauma than women. But then there are other things, characteristics of the traumatic event may contribute to the likelihood of developing PTSD. So we think about the severity of the trauma, the duration of the trauma, and the proximity to the trauma. So if somebody threatens you, you get mugged. Depending on how the mugging goes, may relate to PTSD. So the severity of the mugging. So they had a knife or they had a gun. They had a knife and you got cut, or they had a knife or a gun and they physically made contact with you, or they didn't make contact. So the severity, how bad it was, might play a role. The duration seems to play a role. When we think about abuse situations, something happening once could lead to PTSD, but more likely to lead to PTSD the longer it happens. So kind of chronic abuse. Even you think about sexual abuse that involves penetration being of greater severity. But if there's abuse that doesn't involve penetration but occurs over a long period of time, so inappropriate touching for a long time, that can also lead to PTSD because of the extended duration. And if you have both, you're pretty high risk. And the other thing, which is probably newer to our thinking, is this idea of the proximity to the trauma, and both physical proximity and psychological proximity. So a bomb goes off, and you're right next to it. It's generally thought to be more traumatic than if you're a mile away, but you can see it, and some shrapnel lands 100 yards from you. You're less close to it than if the shrapnel lands behind you, went over your head. So one event is thought to be more traumatic than the other because of your proximity to it. And if we look back at data from post 9/11, looking at the experience of post-traumatic symptoms in New Yorkers, if you lay out a map and you start to code on that map for the severity of symptoms after the towers collapsed, you'll see people who live in neighborhoods close to the towers have the highest number and severity of symptoms. And as you go out in kind of concentric circles from the epicenter of the trauma, you'll see fewer symptoms and less severe symptoms. Right? So the physical proximity to those towers coming down was related to the experience of traumatic events. And the other thing, in addition to physical proximity, is psychological proximity. So the person next to you gets shot in the head. If they're a good friend of yours, that you have a closer psychological proximity than if it's a complete stranger. Both could be traumatic, but one's probably more likely to be traumatic than the other because of the meaning assigned to it, and again, how psychologically you are close to that traumatic event. Okay. So we just talked about characteristics of the trauma. I have that on here twice. And also intrapersonal risk factors, so things about yourself, which I already said that some people may be more prone to experience trauma in the first place. On the flip side, in terms of protective factors, higher cognitive functioning, so higher IQ has been found to be a protective factor. So if you experience a trauma, but you have a higher IQ, less likely to develop PTSD than people with lower levels of cognitive functioning. People that have experienced trauma, if they had a pre-existing psychiatric disorder, they're more vulnerable to develop PTSD, especially if it's an anxiety disorder. People that have previously experienced other traumatic events, it seems to have this kind of additive effect. There may be a role for negative metacognitive appraisal. So thinking about your thinking negatively. So when traumatic things happen, many people have reactions to PTSD symptoms, right? But it may be that people who think about their experiences as indicating something bad about themselves, like, oh, I'm going crazy, I'm not strong enough to deal with this. If you have that kind of thought about your thoughts and about your experiences, those individuals may be at greater risk of developing PTSD. And then the other thing we know is that about the person's response during the trauma seems to be related. If they have dissociative experiences, so if they feel, like they weren't there, like their body was floating and they saw themselves, the bad thing happening to them, If they experience dissociation during the trauma, that's a much higher risk for PTSD. But then there are also interpersonal risk factors, so variables related to relationships. So in terms of level of social support after a traumatic event, people with more social support less likely to develop PTSD. Whether or not they were able to make a disclosure of the trauma seems to be related. People that don't disclose to others the traumatic event, more likely to develop PTSD in some cases. And again, the idea that if you don't talk about it, you're not getting it out, you're not facing it, and now you're trying to not think about it, and it's the memory is taking on, the memory of the trauma is taking on more power. But then we also have looking at the level of social acknowledgement, which comes a lot from looking at what happened with our Vietnam veterans. If people around you don't acknowledge the trauma, or if they blame you for the trauma, then that can have a negative outcome and make you more likely to PTSD. So in those cases, a disclosure may not be so good. It's kind of damned if you do, damned if you don't in that instance. So there are other variables about how the world around you reacts and how you are able to talk to people around you that may influence the risk of PTSD. And then, of course, there are biological risk factors. Having a smaller hippocampi, a small hippocampus, seems to be probably a risk factor. And then again, genetics in general, risk factor for anxiety, but then also possibly for the personality traits related to the likelihood of taking risks and experiencing trauma in the first place. Okay. Let's talk a little about some of the key features of treatment, and there are different approaches, but most of them share these kind of three things in common, right? They share managing stress reactions, processing the trauma, and then reestablishing social connections. And different approaches will emphasize one more than the other, and they may do things in different orders and have different terms for referring to these things. But these three basic features are common to most supported treatments of PTSD. So looking at the first one, managing stress reactions. When James talks about it, James talks about controlling stress reactions. But for me, the word manage is more appropriate word choice to my thinking, because you can't really control stress, and that's kind of an illusion, I think, to tell clients that. But we want to help them learn to manage their stress. But they're not. If you're controlling, it implies that you could make it stop and not feel stress, and that's not really a realistic, in my experience, thing to tell people. Anyway, two reasons why it's important to help people learn how to manage their stress reactions. One, we know that PTSD involves some potentially unhealthy and maladaptive responses to stress. So they're experiencing lots of stress. Obviously, they need some help with that, because stress itself causes damage. Right, high levels of cortisol all the time generated by stress puts you at risk for depression and other things. And two, the other key features of treatment will frequently involve increasing their experience of stress temporarily. So they need to be prepared for that. So in addition to the stress they're already experiencing, some of the work you're going to do in terms of especially processing the trauma, you're going to be causing more stress and inducing more stress reactions. So you got to make sure that they're well armed with skills and techniques to deal with what they need to do to recover. Okay. So this might involve activating known coping skills, right? Finding out things that have worked in the past and then maybe have been abandoned, or maybe for some reason they feel like it's just not an option in this current situation, and then problem solving with them about whether, might that work? Might some adaptation of what's worked before work now, right? So again, we're not going to reinvent the wheel. So what do they already know how to do and what's worked in the past? Well, we probably are going to teach them some new skills. It's new for most people in a variety of things, depending on what you're comfortable with and what the client responds to. But things like progressive muscle relaxation, breathing techniques, guided imagery techniques, all of which you can read more about elsewhere. But there's lots of techniques for helping people learn to manage anxiety as it comes up in a session, and also as it comes up in their life. And again, these aren't things that don't try to fix your problems, just manage the stress all the time. No, these are things to manage stress enough that you can gather resources to solve problems that are causing the stress, right? And it's the same thing here. We're trying to teach you some tools to manage your stress enough that you can do this other stuff. And the main thing with treating PTSD, the other stuff, really is the processing of the trauma, right? We talk about processing trauma. Sometimes the word processing may seem a little ambiguous here, and really it means talking about the trauma. The person, not you talking to them about what you know about it, but them talking about the traumatic experience, the traumatic memory. But it's more than just talking about it, right? It's talking about it in a context that allows for the experiencing of the trauma, thinking and feeling related to the trauma in a way that will lead to changes in how the person feels and thinks in the future about the trauma, and in how they respond to stimuli associated with the trauma. Right? And there's a really strong cognitive aspect to this, in terms of giving meaning to the trauma and finding a way to integrate it into your own life story, and if not why it happened, some understanding of that there are no explanations and things don't happen for a reason. But then there's also another more experiential, emotional aspect to processing that needs to take place. It's not just cognitive, it's not just emotional, experiential. Both of those things seem to be really important in terms of the processing of the trauma. Now, depending on what approach you're using, it'll depend how quickly you move to from shallower processing to deeper processing. How much of their senses you're going to be engaging as they're processing, how much of the memory they're going to be asked to talk about, and what level of detail, all that stuff. And again, depends on your therapeutic style and your theoretical orientation and lots of other things. But it depends, and there's not a cookbook to tell you, well, it's this much, this fast. And then also the length of exposure. So how much processing you're going to do, how many times they're going to be telling you the story, and when they're telling you the story, how long they're going to spend doing that. Depends on what type of therapy you're doing. In terms of EMDR, eye movement desensitization and reprocessing, this is where you add some sort of bilateral sensory input into processing. The classic way is where they have the finger going back and forth in front of the client's face, crossing midline, and the client's tracking with their eyes while they tell their story, talk about the trauma. But people have also done it with sounds. They'll have a sound go off in the right auditory field and then the left, and they're supposed to try to track that, listening to the right, listening to the left while telling their story. And there's no documented or accepted reason why this works. But there's plenty of research out there saying that EMDR works. But the caveat being that there's some research that's compared EMDR to doing similar kind of cognitive behavioral exposure work, where you do everything just like you would with EMDR, except you don't do the finger back and forth. You do all the other pieces, but not that part, which they say is the key part, and that there's no difference for at least some clients. And given that there's no explanation for it, a lot of therapists are uneasy about doing it. Others just say, well, it's work, so do it. Who cares why? And it can be difficult trying to wade through the research here, because sometimes the people are so passionate about the topic on either side, either EMDR is great or EMDR is a sham, that their scientific objectivity may be a bit compromised. So it's a loaded issue. It does work, but does it work any better than not doing the back and forth stuff? That's debatable. So then you have to think for yourself, ethically, morally, professionally. If I'm not sure I need this other thing, and it seems more kind of smoke and mirrors, is that okay to do? Or if you think of it, well, it's something that makes the client more comfortable, then that's why I should do it, regardless if it has anything to do with kind of the brain processing in both hemispheres. Is it still okay to do? If so, should I tell the client that it has nothing to do with their brain and it's really about making them comfortable? And you've got to figure that out for yourself if it's something you're interested in exploring. But regardless, whatever you do, you're going to be processing the trauma, either with or without the bells and whistles. And then the third key feature is reestablishing social connections. Remember, one of the three core symptoms of PTSD is numbing and avoidance, right? And often this is manifested in withdrawal from interpersonal contact. it's pretty well established that we need relationships, we need interactions to be psychologically healthy. And some evidence also suggests that we need interactions, we need relationships to be physically healthy, right? And also some of the other symptoms of PTSD, the re-experiencing the arousal, might contribute to the formation of unhealthy relationship patterns that need to be addressed. So that's why one reason that this is so important. So clearly, people with PTSD often have pulled out of relationships, part of the symptomatology of the avoidance, and then also the other symptoms. Even if they haven't pulled out, they may have some screwed up relationships. Things might not be going well because of their other symptoms that are affecting their relationships and affecting the other people in the relationships. Right? And you think, well, if we treat the other stuff, we change the individual, then the relationship will go back to being normal, right? And those of you who have studied your family therapy should say, well, maybe, not necessarily. Like sometimes we can get a system to change by changing one person. But more often than not, the reason that we have family therapy and couples therapy instead of doing individual therapy is because there's a recognition that even if one individual changes, the system is often resistant to change. Right? So if that person gets better, if they're in some relational context and the relationship can't handle them getting better, then the relationship, the system, will exert pressure on them to no longer be well, right? Or that relationship will crumble. So we have to address these relational needs in addition to the individual needs. So that may involve family therapy or couple therapy, because we know that the support and understanding of those closest to the person is clearly of great importance. And PTSD does seem to have a profound influence on marital relations. Couples where one member of the couple has been diagnosed with PTSD, those couples report lower marital satisfaction, higher rates of marital conflict than couples where neither person experiences PTSD. And even higher rates of marital conflict when then looking at some other psychiatric disorders. So not just looking at with disorder, without disorder, but PTSD in particular seems to be more disruptive to relationships than some other disorders. Okay. So family therapy, couple therapy, often vital to success, either after individual or as an adjunct, same time as individual. And then group therapy. And different types of groups might be helpful at different points in the person's treatment and recovery. You might have psychoeducational groups where they're learning about PTSD. There might be support groups. Support groups of other people that have also been diagnosed with PTSD or have also experienced traumatic events, to talk about their experiences and learn from each other. And then there also might be kind of interpersonal process groups, where after they've dealt with a lot of the processing and trauma stuff, and now they need more to work on the social, reestablishing social connections, reintegrating into their world kind of issues, which interpersonal process groups often good for that sort of thing. Okay, so it's important to be familiar with the key features of treatment for PTSD, but it's unlikely that you would treat PTSD as a crisis interventionist, right? You don't have that much time, usually. Treatment of PTSD typically not done in a couple of sessions, and there's some people that do some versions of EMDR that say they can do it in one session, 4 sessions. Personally, I'm skeptical of those cases. I'd like to see some longitudinal follow-up data before I feel good about that, and it may be restricted to only a small number of people. So generally, you're going to be focusing on some other stuff, and not on, okay, this person's in crisis, I think they may have PTSD, let me think about how to treat PTSD, that's what I'm going to do in crisis intervention. No, you have to keep your focus on crisis intervention. Not to say that it's not important that you need to keep an eye out for PTSD. So, obviously, assessment's important. You need to know if you're dealing with somebody who has PTSD or not. So they may come in and have been previously diagnosed. They may not have, and the trauma may be fresh, and they're developing symptoms, or the trauma may be somewhere in their past, and they've just never been appropriately diagnosed, either not diagnosed at all or maybe misdiagnosed. And now they're presenting to you in crisis for something not directly related to the trauma, but their current presentation is complicated by the presence of PTSD, right? So you want to get a good assessment. If you have the time and the resources for formal assessment, the CAPS, clinician-administered PTSD scale, is probably has the most empirical support, and there are multiple versions for different populations. If not, as more often not be the case, it'll be interview, right? So you need to be asking the right questions in an interview to diagnose anything, including PTSD. And again, usually in crisis intervention, we're not really focused on this kind of systematic diagnostic procedure. But for PTSD, it may be important in terms of what we're going to be recommending and the steps we're going to be taking, how we're going to see this person, how we're going to treat this person, to know if they're having if they have a PTSD reaction already formed, or if they're in the process of forming one. Right. So this means that obviously you need to know the diagnostic criteria for PTSD, but that in itself is not enough. Right. You need to know how to word questions to get good information about whether or not they meet criteria. Right. If you just ask, "Do you?" and then you read the criteria out of the DSM verbatim, you may not get valid data, right? Because the manual often has things worded in a weird way because it's written largely by psychiatrists for other psychiatrists, not written for clients, for patients. Right? So it uses kind of psychiatrist language. If you're not sure how to ask questions, take a peek at one of the structured interviews for diagnosis of PTSD. And you don't need to memorize the questions on one of the structured interviews verbatim. And okay, well, question one is, I remember now. But if you read over it, if you're not comfortable, it'll give you a better idea for how to ask those questions. Okay. Then in terms of what you do with people, if you're not going to be treating their PTSD, you're going to be doing crisis intervention, right? So a lot of what you'll be doing that will overlap with the treatment stuff is in terms of the managing the stress reactions. Right, and so you may be spending more time with somebody that has PTSD, already developed a PTSD kind of syndrome than other people in crisis, in terms of helping them learn to manage their stress reactions, because you can expect that to be a more chronic thing and possibly a more debilitating thing for them in terms of their experience of stress. Right? So a lot of it will be consistent with what we talked about before in terms of providing support, but you may be doing some other stuff as well, but you're probably not going to be doing much processing of the traumatic event, right? And one reason for that is there's a danger of premature processing, right? If they don't have the skills, the managing stress reaction skills built up enough, and you push them into processing, you may simply re-traumatize them and make them more traumatized. And put them further behind in terms of their recovery. So what do? You focus on the current crisis. Right? So you're not going to ignore that PTSD complicates treatment, but you need to focus on the current problem that brought them to you. So they're coming into you today because their spouse left them, they got fired from their job, whatever it is. Right? Because remember, the goal in crisis intervention is to get the client stable and mobilized enough to take action toward addressing some immediate problem. And even if they have PTSD, that's still your goal. Right? So some other things you're going to do on top of that, if you've established that they do meet criteria for PTSD, is probably some psychoeducation, right? You're going to educate them about what PTSD is, what treatment might look like, right? So here's kind of the things that most people will do in treatment, and it won't be me, because depending on your setting, I'm going to refer you to someone and they'll do things like this, and you're going to talk about the traumatic event, but they're not going to make you do it the first time, and they're going to teach you how to get comfortable and how to help, learn how to help yourself calm down when you get anxious, because these memories cause anxiety, right? So you talk through all that stuff, and you talk about the possible outcomes if they choose treatment or not, right? And you don't say, if you go to treatment, everything's going to be fine. You say, if you choose treatment, it's going to be difficult, it's going to be hard, and things might even get worse for a while. Right? You may experience more anxiety than you're experiencing right now. That's a possibility. But if you don't, the course of PTSD, some people will eventually get better. From what we've looked at in the research, looks like those who meet criteria, which means that you've had these symptoms for a while, right? So for over a month at least, people that have them that long, they don't go away. And they may subside, but then they'll often transform into other problems. So if you don't deal with it, it will come back and get in the way of you being happy and getting what you want and living fully. So there are a lot of reasons to get treatment. Again, treatment may be hard, and it may not work the first time with the first therapist you meet. You do all that stuff, but then you talk about the importance of doing it and what happens if you don't seek treatment. And then obviously you want to provide referral information for all the services that are going to be needed for that individual. Probably individual therapy, maybe group, maybe family, and then also possibly if it's a military veteran, if they're not already in touch with veteran services, get them hooked up to make sure that they're getting the support they need in terms of financial support, but also in terms of what they're going to be expected to do if they're still active military. So that they're not being sent out into a combat situation before they're psychologically ready. So they need an advocate for that. And then if they're somebody who's PTSD who's been a victim of a crime, somebody who's been a victim of a sexual assault, possible referral may also include legal services, right? In terms of here's your options in terms of reporting somebody who's assaulted you and trying to prosecute them. So providing with all the relevant referral information, and so again, someone with PTSD, it's important to know about treatment, largely because you want to talk to them about it, and you don't want to point them down the wrong road. But again, you're probably not going to be treating PTSD in crisis intervention. Okay. And again, there's the temptation to make them, process harm is good, talk about it now, and we'll just make yourself talk about it. For some people that may help, but for some people it may cause more damage, and so you want to be cautious about doing that. And if you do the individual therapy for PTSD, you want to be cautious about pacing a client and know, have a good idea of what their strengths and weaknesses are and how dangerous it is to push them at a certain rate. Okay. In terms of discussion question, I want you to imagine that you have met with a client, comes in for crisis, right? And your assessment suggests that they probably suffer from PTSD. You interview, they talk about this traumatic event. Let's say that perhaps they were a soldier, right? And there was a battle that they were in. Person next to them mortally wounded. They saw it, couldn't help them. And then soon after started developing classic symptoms of PTSD, and those symptoms have persisted now for 3 to 6 months. It's been a while, right? But they're not coming in today for you for that. They're coming in because of relational problems. Their spouse has said that they're going to file for divorce and take the kids, and so they're decompensating, a little bit suicidal, not sure what to do. And you, in your course of assessment, you tell them, seems like you might suffer from PTSD, and they angrily deny that they have PTSD. They tell you that they don't believe PTSD exists, that it's people just faking, and when bad things happen, people should just suck it up, and that they don't want to hear another damn word about it, and they're here to talk about how to get their spouse and kids back. If that's the client and you're doing crisis intervention, what do you do? Not in terms of tell me everything you do, but do you say, okay, well, I'm not going to talk about PTSD anymore. I'm going to focus on what the client wants to talk about, and we're going to talk about how to get your family back? Or do you somehow say, no, that's not an option, to pretend like PTSD doesn't exist, because your PTSD is probably part of the reason that your spouse and family aren't here. And if you don't get help for that, you're not going to get them back. Which do you do? You go with what they've told you, that they don't want to talk about it, and focus on the crisis without somehow talking PTSD at all? Or do you try to convince them, educate them, whatever, about PTSD? Which road do you take? And so just say a little bit about that and why you would do one or the other. Okay, that's all for now. Take care.